Thanks, Tim and Kim. And before we start, did I hear that there's somebody in the room there from Indian Hills?
Yep. Yes.
Um, I need to ask them, I think it was a him, a question. I use your signs all the time, and you're going to see them in this presentation. Who comes up with those? Is that you that comes up with those?
No, I wish it was me. It's a guy named Vince. He lives in the district.
And he's just a guy.
He's just a guy.
He's not like a professional sign pun person. He's
No, not at all.
Yeah, and I got to tell you, I use, as you'll see here in a minute, I use his stuff in a lot of these presentations. So if you see him, please tell him that we're pimping him a lot around the country. It's just, because he does just an amazing job. So, well, Tim and Kim and everybody, thank you so much for being here. Sean, there are some familiar faces in the room, so thank you guys for inviting me to be part of this. And unfortunately, you're going to have to hear from a couple of us multiple times, so we're going to try and keep this relatively interactive as to the extent that we can, but certainly try and keep it relatively fun. And kicking off the whole event with calculating costs was, as we thought about it, as I thought about it, Kim, maybe not the shrewdest thing in the world, although people may be more awake now than they will be throughout the rest of the couple of days. So hopefully this will be something that they can absorb a little bit. We're going to try and keep it relatively light and hopefully insightful and maybe even a little bit controversial. So what we're going to do over the next hour or so is just highlight the status of EMS economics. And as we all know, it's kind of a mess, but we're going to highlight the mess. We're going to give you some resources that you can use to show your local community how much of a mess it really is nationally. It's not just your local community, perhaps, but it's happening around the country. We're going to talk about some of the funding opportunities that have opened up over the course of the last probably 7 to 12 months and learn how we are helping people capitalize on some of those funding opportunities. We're going to talk a lot about the pitfalls of defining cost, because if we were to survey the room right now and ask everybody to write down what their cost per unit hour, what their cost per response, cost per transport, et cetera, might be, a lot of folks don't have it top of mind and might calculate it differently. So we, along with a number of other associations and groups, have tried to hone in a little bit and help people how to really get to the root cause or the root definition of what costs are. And then we're going to use that to do some cost calculations examples. We're going to use Anytown USA as an example and kind of walk through that process. Before I forget, and Kim, remind me if I forget to say this later, there is a template workbook available that is on the NAEMT website. It's also a couple of other locations. And if your participants would like to have it, happy to send it so that you guys can have it and use it to help do some of the calculations that you're going to see us walk through over the course of the next hour or so. And not even knowing that there was going to be somebody from Indian Hills in the room, we're going to have some fun with signs. And this is something that I love to do. It's one of the silly things that we try and put into some presentations because, again, these are just simply hilarious. And if some of you have seen them live before, I apologize because they're not going to be as fun as these are. But underwear bandit caught admits brief crime spree. I thought that was pretty clever. This guy is amazing. Attention thieves, please carry IDs so we can notify your next of kin. One of the things that's fun about living in Texas, we did an analysis last year, and interestingly, MedStar responds to about 2 or 3 on a good day shooting calls per day. And oddly, about 30% of our overall shootings are perpetrators that become victims of a gunshot injury. So we tell people, if you're stupid enough to try and burglarize someone's house or rob them, you're going to get shot. And it's just, we call that natural selection here. So, okay. So the plight of EMS economics across the country has gotten a lot of local and thankfully national media attention. We often say never let a good crisis go unleveraged, and the pandemic accelerated some of the challenges that we have as a profession, and it really put us in the spotlight in a positive way because of many of the things that you all did in Colorado and helped with coronavirus relief and vaccines and testing and monoclonal antibody infusions. And we got a lot of recognition for that, but it also showed the real fragile system models that many of us have, certainly when it comes to staffing, economics, supply chain, all of these things that we've been hearing. And there's a number of folks that have been tracking these national and to a large extent local media stories, and it's circulated weekly. So Rob Lawrence kind of spearheads this, but a number of folks contribute to it. And there's this running log of local and national media stories. And as you can see, this log can be filtered based on the focus, or at least the themes of that article. Was it a rural health issue? Was it about vaccines? Was it about response time, staffing, call center operations, ambulance ER delays, funding? So far, as of Monday, this past Monday, we've been able to identify 545 national and local news stories that had EMS as its focus. Now, 59% were about staffing challenges, but 106 of the articles really highlighted the economic issues. And this phenomenon, if you will, and this media focus really helps to a large extent tell our story, so that it's not just the local EMS director, fire chief beating the drum in your local community saying, hey, we're in trouble, we're in trouble. It's happening pretty much across the country. So we'll make sure that the folks have access to this. I'll send you the most recent one. You can search it in a number of different ways to find articles that you might want to be able to highlight or refer to. Now, interestingly, during the coronavirus pandemic, the government, federal government specifically, opened up a huge spigot of money. And a lot of that money went to states and some local governments. The trade journal for the National Conference of State Legislatures did some research that they published in June, and they found that only about 28% of the ARPA and even to some extent the CARES Act monies have been allocated by local jurisdictions and state jurisdictions. So in your community, you may find, or in Colorado, you may find that there's a pile of money that legislators and elected officials are trying to figure out what to do with. We just had a big thing happen here yesterday where our county, Tarrant County, just allocated another $44 million to a homeless initiative using ARPA money. And it's still sitting in their bank, and they're trying to figure out what can we spend it on that meets the guidelines. So EMS has risen to at least the top 5 of things that people are beginning to look at. Do we need to provide funding? Now, the challenge is most of us do not need, although we won't turn away, but we don't need grant dollars. We don't need, it would be nice to have money for a new ambulance, but we can't get them anyway. But really, we want to focus on the long-term funding of EMS and getting, 5 million, 1 million, even, in our state, we got $27 million for workforce development. That's a grant, and that's going to go away. That's not going to help us pay the money that we need to pay for EMTs and paramedics and others and dispatchers to work. So as you're having conversations about financial issues in EMS and costs and funding and revenue streams, always keep in mind that the gold ring that we really need to be working towards is sustainable funding, not one-time grants. Love Siren Act grants, it's great. Love the HERO Act that's being circulated around now, but those are grant dollars. Yes, it helps, but we just need to fundamentally change the economic model for EMS. And you can use this opportunity with funding that you get to perhaps demonstrate what that's going to look like. Now, here are some examples of states and local governments that have taken that unspent CARES Act and ARPA money and really changed the economic model for EMS. Some of these are long-term. So you see a big effort in getting Medicaid payments to be in parity with Medicare rates. And that's parity with a T, Sean, just so you know. Because we all know that Medicaid dramatically underpays what it costs to provide service. And one of the ways to help improve the systemic and sustainable funding for EMS is to get Medicaid to pay a reasonable rate. So again, you'll see a lot of states are beginning to do this. This is on our legislative agenda for the Texas legislature this year, but a number of states have done a really good job. And I know that through Tim's participation on our advocacy committee and a number of other organizations and his role in the EMS economics committee, Colorado is doing a really good job with this, specifically with regard to commercial payers. But those are things that are going to be really important to keep the fire on those issues as time goes forward, because it's going to be very, very important. All right, a couple more signs. Kleptomaniacs always take things literally. It's kind of clever. To the thief who took my antidepressants, I hope you're happy. Just gotta find out what it is. Okay, so we talked a lot about this already, but if you think about sort of this part, right, the spigot that's here, pennies are fine, but we really need dollars. This is something that when you talk about essential service, cost of service delivery, what we're going to do this morning is to help you identify what is your true cost of service delivery. So when somebody says, how much money do you need? It's not just a Band-Aid fix. It's a fundamental, yeah, you know what, the days, and we've said this before, and I know Sean's heard this on some of the meetings that we've been on, the days, for the most part, the days of an unsubsidized ambulance service provision in your community are pretty much over. Those of us that were able to do it, and we did it at MedStar, we've been unsubsidized for over a decade, but those days are over because the fee for service has not increased at the same level as our cost, primarily our human resources cost, when probably like you guys, we've had to do a 48% increase in our wages in the last 18 months just to keep people from going to work at the hospital. Hospitals love EMTs, they love paramedics. We just saw an ad that came out yesterday from our second largest hospital in downtown Fort Worth. They're starting their winter bulk up of personnel, and they are offering new paramedics to go work in the emergency room at $48 an hour with an $8,000 sign-on bonus. We can't compete with that. So we know we're going to lose a whole bunch of paramedics who are going to go work in the ER. They never get a late call. They don't have to, slap around in the bad weather because it's air conditioned in the hospital, and the 3 or 4 days that you need heat, it's heated to freeze to death when we're out there. But again, these are things that we need to keep thinking long term. Now, when we start doing, keep in mind, if you are determining your costs, you have to differentiate your cost of fire service delivery with your cost of EMS delivery. And you'll see why that's become really important here lately. And make sure that you're separating out just the cost for EMS separately than the costs of readiness, if you will, for fire service delivery. And especially when it comes to actual ambulance delivery, because those are many different service lines. If you're a combined system where you've got engines going on a first response and the ambulance responding with the engines, or you're mixing and matching, it is getting really important to not mix red dollar with green dollar. And you'll see why as we kind of go through this a little bit. But when you do cost analysis, just consider what's your cost of fire service, what's your cost of first response EMS, what's your cost of ambulance service delivery. They need to be very different. You may have all seen this memo that came out in the middle of August from CMS. If you haven't seen it, let us know. You can download it when I send Kim the PDF of this. There'll be a hot link in the PDF. You can download the actual memo. But this memo came out and specifically reminding states and providers, primarily states, that when it comes to things like GEMT, or whatever you call it in the different states, in Texas we call it the Ambulance Supplemental Payment Program, ASPP, and other places they call it GEMT, only the cost of ambulance service delivery is eligible to be counted when accounting for the costs for a GEMT program. Because the federal government has said long ago that costs related to first medical response, if they are in a fire department, for example, or a police department for that matter, are not a covered expense for Medicaid. And if it's not a covered expense, the costs cannot be counted towards a GEMT supplemental payment. This became a big issue when we were working with RAND to develop the ambulance cost data collection program for CMS. And if you've taken any time to look through that voluminous instruction section for that process, it is very specific to exclude completely any costs related to first response, any costs related to anything that's not specifically related to ambulance in front of an address. For example, a fire station that has 3 fire trucks and an ambulance parked in the fire station. The cost of the station can only be counted for the 400 square feet that the ambulance is parked in. You cannot include the cost for the station where the trucks are parked, the fire trucks are parked. Very, very specific, especially when it comes to things like personnel. So this was a shot across the bow. Where this came from, we're hearing, no one knows for sure, is because of 2 things that happened relatively simultaneously. The first was that in Texas, we were successful in convincing the Medicaid commissioner to change how the ambulance supplemental payment program, the GEMT program here, is calculated. And you'll see why in a minute. That shone a huge light on the actual cost data between different types of providers and what was being reimbursed to those types of providers. And you'll see that in just a minute. Texas and the Biden administration are going back and forth on approving the state plan amendment to change how that cost is calculated or how that difference is calculated. The amendment to change was approved by the Trump administration, essentially, and I should have said this earlier, I apologize. The plan for Texas is to move away from cost-based reimbursement and move to a difference as a basis, the difference between what Medicaid pays for an ambulance trip and what the average commercial reimbursement is for that agency. So what that means is if we, MedStar, bill a market rate and our average commercial reimbursement is $1,500 and Medicaid typically reimburses $280. The difference between $280 and $1,500 is the basis for calculation of how much supplemental payment we will get, not based on our cost. And again, you'll see why in a minute. That was approved by the Trump administration. Express, good to go. Medicare, CMS wants to come off cost-based reimbursement. They did that with the hospitals in the 80s. They wanted to do it with us. At the same time, New York City FDNY was getting ready to submit their first cost report to take advantage of New York's GEMT program. And Medicare looked at that bill and said, holy crap, that's a boatload of money that the feds are going to have to pay, 65% of. So CMS really began to look at what's happening in Texas and what was recently filed in New York and said, wait a minute, why are these costs so different? There's only one way that these costs can be so different. So that's why they sent this note. It said, hey, you cannot include cost of the engine. You cannot include the cost of the personnel in the engine. You cannot include anything other than putting an ambulance in front of the address, period. Now, I will share my belief here is that this shot across the bow was the warning to say, we're going to go back and audit all of those cost reports. And if you have included non-eligible costs in your cost report, we want the money back. I think that's coming next. And there are going to be a lot of agencies that are going to be in a bit of a pickle. And here's why. Uh-oh, did I not? Okay, we're going to come back to that. That was a good teaser. Okay, so here's the basic analysis. So you're an ambulance provider, or you have an ambulance service, whether it's in your fire department or it's a community-based service or whatever, and private hospital-based, whatever. Couple of things to help serve as the basis of this calculation. And again, I said we were going to use Anytown USA. So we're going to keep this very simple. And then you just have multiples of this when you start working through the cost of your service delivery. So this population is 40,000 people that are served. They run one ambulance, 24 hours a day, 7 days a week. So that is 8,760 unit hours. Okay, so they're on duty 24/7, one ambulance, there you go. They do 2,000 calls a year. And from those 2,000 responses a year, they transport 1,400 patients, 1,401 to be exact. So when you look at that analysis, the first sort of litmus test is their unit hour utilization, which is the total number of ambulance unit hours, or total number of ambulance transports divided by the annual unit hours of 0.16. Now, that's just a number. And depending on how your system is structured, depending on your task time, depending on all sorts of different things, that number could be good or bad. It's just a number. It's a way for you to determine the activity level within this particular agency. I would also share that it's not a bad idea to calculate this for both response volume and transport volume. Many locations will only do it based on transports, but we calculate it based on both responses and transports, because as you can probably imagine, being an ET3 provider agency and doing a number of things and having a couple of different payment contracts that pay us to respond, doesn't pay us to transport, our transport ratio is going down. So if we were only to use transports, it's not really a true measure of the activity and the utilization within our system. So more and more we're relying on the response activity because our transport ratio keeps going down, which is good. I mean, that's the desired goal. It's bad from the standpoint that typically if you transport less, you get paid less, which goes back to the fundamental flaw in our entire system. So let's look at some of these expenses for Anytown USA. So they have 7 FTEs to staff the ambulance. They make $80,000 a year. I'm sorry, their cost, that's an important differentiation. Their employee cost is $80,000 a year. That includes pay, benefits, uniform, all the things that you see listed there. If they get turnout gear, if they get flak jackets, if they get, whatever, that's the total cost, including pension contribution. This is something that many agencies forget to include in their FTE cost. You have to include that. Whatever costs are related to that employee, you have to include as your cost per FTE. The ambulance, $250,000. We did this last year. It's probably now closer to 310. But depending on the type of ambulance, whether you're going to get an International Harvester, or you're going to get a Ford Sprinter, could be different. Cost of the cot monitor, the capital cost, then in this case, for $315,000. Now, important to note that some cities, specifically in counties, don't necessarily do depreciation costs the way that other people do. It is very important that when you're estimating your cost of service delivery, your cost of capital has to be included in your estimates. Because if you don't do that, then you're not going to be able to identify the cost to replace that ambulance in 5 years, or to replace those cardiac monitors in 3 years, whatever the case might be. So when you're doing your cost analysis, in this particular example, we gave you the capital costs of $315,000. The average useful life of that vehicle is going to be 5 years with the equipment, monitor, et cetera. Technically, you could break this out into the useful life of the ambulance, useful life of the cot, useful life of the $5,000 portable radio that you have to put in there, that kind of stuff. So in this estimate, we've got $63,000 of depreciation expense. Very important to include that in your cost because you're going to have to replace that ambulance and other stuff eventually. Then your other expenses, maintenance, fuel, supplies, whatever else you can come up with that are part of your operational costs. So for Anytown USA, their total annual cost or expense per ambulance, $689,750. You can do the same thing in your community if you've got 3, 4, or 5 ambulances, whatever. Just it's times X number of ambulances that you have, depending on how often they're staffed. Is it a day unit only, whatever? And you can do this. So then you can do your cost per unit hour, cost per response, and cost per transport. So very simply, if you take that 689, we'll call it 690. If you take the 690 divided by the unit hours, you come up with a unit hour expense at $78.74. So for every hour that an ambulance is on duty, it costs you $78. So when your local, I don't know, community group says, hey, can we have an ambulance for 4 hours and we don't want to pay, will you donate the time? At least this gives you a cost basis to say, okay, if we do that, it's going to cost us $250. We want to be listed as a $250 sponsor, and we want our logo on your t-shirt or whatever, as an example. Then cost per response, again, just take the 690 divided by the number of responses, and then your cost per transport is your transports divided by your total expenses. These are important numbers when you start talking about what the average reimbursement is that you're getting per transport or per response. So these are talking points, and your costs might be totally different. Your cost might be $3,000 a transport. Okay, that's great. Then you should get $3,001 reimbursement for the transport, just to make sure that you've got that sustainable revenue stream or funded in whatever way it's going to be to match that expense long term. Now let's talk about first response. So if you do the same thing and you say, okay, we've got a fire agency, or we also respond to some calls, maybe all calls, as a first response unit. Okay, so let's look at that first response unit over there on the right. So one unit, 15 FTEs, right? 3 people, 4 people on the unit, whatever. What paramedic differential are they getting? So in this case, they get a $3,000 paramedic differential. I'm hearing recently that that number is more like 10,000. So put in whatever number that is there. How much expense do they go through for EMS training? Not fire training, EMS training. So CEs, recertifications, those have to be included in the cost for that expense. Now, why are we not including the cost of their payroll? Because they're there for fire calls. If, and this is the litmus test that we use with agencies all the time, when people say, well, it cost us $3,000 to send an engine on a medical call. Okay, let's talk about that. The cost of the engine is pretty minimal going to a medical call because, sorry, sound of jets going over our headquarters here. The engine is on duty for fire response. They happen to do medical calls. So we often ask the fire chief, if you were to stop responding to medical calls today, just stop, how many people would you lay off? And the answer is typically none, because we need them for fire suppression. Okay, if you need them for fire suppression, then their personnel cost is not an EMS cost. What's an EMS cost is the additional expense for having them respond to medical calls. Because if they stop going to medical calls, they don't need to be EMTs, they don't need to be paramedics, they don't need a cardiac monitor, they don't need, so you take all of the medical response equipment and things off the truck. Now, you might have some wear and tear, you might have whatever that gets saved, but most honest fire chiefs will tell you that they generally don't replace fire engines because they wear out. They replace them because they become obsolete and they can't get parts. It just doesn't have the current stuff. So even the wear and tear is typically a very, very small expense. So you take the fuel into account, you take those medical supplies into account. So the total annual cost of first response for this particular fire agency is, a whopping $11.99 per response. Per unit hour, because it's, again, minimal expense, and the cost per response is $52. And I would argue that that's pretty accurate, because again, if they didn't go on the call, they would just be sitting in the station. You're paying them anyway. So the additional marginal expense of going on the medical call is pretty small. Okay, so fairly straightforward calculations there. You add that to the unit hour cost for the EMS response, and you see what it does. So it's $90.72 total cost, system cost to go on a medical call, $397.38 per unit hour, I'm sorry, per response, and $567 per transport. Just simple math. But again, that gives you a very good, when someone says, how much does it cost to go on a medical call? Here you go. How much does it cost to staff an ambulance per hour? Here you go. So again, it gives you that cost basis. Now, let's talk about a couple things that you need to consider. If you're going to be asking for money to help sustain your ambulance service, people are going to ask questions. Well, why do you need it now? How come you didn't need it before? You need to answer that question. They'll begin to negotiate with you. We'll talk about that in a minute. So let's say, what happens to Anytown USA if they increase their wages by 25%, which many of us have had to do. You heard here we did it 48%. This is how it changes your unit hour cost, your cost per response, and your cost per transport. And you can build that into your discussions. Hey, this is, we're going to increase pay next year just to retain people or to attract more people, whatever. So you can build these things into your cost analysis. So if you increase pay rates by 25%, increase your cost by that amount, makes it pretty simple. Now let's talk about cost based on level of service delivery. It is one of the primary drivers of cost, because depending on what the community expects for response time, what they expect for clinical capability, those are big cost drivers. So let's say in this community, they have a 7-minute response. They have a response time of 7 minutes at 90% and an average of 5 minutes. And Sean, I would argue that's probably pretty close, right? Because if you've got a fractile of 7, your average is probably 5, but you can play with those numbers and see depending on the community. And they want all ALS. So to do that, you have to have a unit hour utilization of 0.136, and that takes 4 ALS ambulances. And you can see that the cost per unit hour for those units is $171.98. So the total expense to the system for the ambulance component, $6 million. So that's what they're spending today. Okay. So when you start asking for money because you need sustainable revenue, or you got to increase your budget, whatever the case might be, they're going to say, okay, I get that it's currently costing $6 million to provide all ALS, 7 minutes at 90% reliability and a 5-minute average response time. Well, what can we get for 9 minutes? What's it going to cost? So now the question becomes, okay, well, let's take that to this extent. So we can eliminate an ambulance because we can increase our unit hour utilization, and we can eliminate that unit, which saves us $1.5 million. So the cost to the system is now only $4.5 million instead of $6 million. That is a conversation that's happening all over the country. When EMS agencies are saying, hey, we need $4 million subsidy to provide this current level of service, a lot of communities are saying, so what's the appropriate level of service? Maybe 7 minutes isn't it? Maybe 9 minutes isn't it? Let's take it to the next level. What is the public expectation? Now, interestingly, we hear that argument a lot. Well, the public expects that we're going to have an ambulance on scene in 7 minutes, 90% of the time, and it's going to be a paramedic in every ambulance. Well, clinically, we know that for 90% of the calls, none of that matters. But who gave the public that expectation? We did. So who's responsible for changing that expectation or right-sizing that expectation? Perhaps we are, based on current science, based on evidence and all the things that are out there. But we did a little interesting scenario here, project in our service area. And we have 1 million resident population here, pretty busy system. And most of our fire agencies do not respond. All right, let me say that a different way. Most of our low acuity 911 calls, Alpha and some Omega, some Bravo calls, do not get first responders, the majority of those calls. So we've been using the EMS survey team for, almost 10 years now. We started using them in 2013. And one of the questions in the EMS survey team survey is, a Likert scale from 1 to 5 of the customer, the patient's perception, their satisfaction with our response time. And the question specifically says, on a scale of 1 to 5, 5 being well satisfied, 1 being least satisfied, how satisfied were you with the timeliness of the ambulance response? And we went back and mined almost 14,000 responses to that question in cases where a fire department first responder did not go. It was an ambulance only response, and we responded no licensed siren. And our phenomenal data analyst, sorry, I was stumbling on the word there, built buckets, bins, she calls them, based on response time, and compared, because we had incident level detail for each one of those survey responses. So she went back and analyzed at what response time bucket was that response received, 4, a 5, a 2, a 1, whatever. And here's what she found, is that we were getting 4.7, 5.0 scores for patient satisfaction with the ambulance arrival time at 45 minutes. 45 minutes. And if you think about it, that makes perfect sense, because these were low acuity 911 calls, ambulance responded only. So, the fire department said, well, the reason you're getting such good scores is because the fire engine arrived and they didn't know when the ambulance arrived because the fire truck was there. Well, it's not true, because these calls didn't get a fire response. So the patient knew they had a low, the fact that anybody came within an hour, they were pretty happy with. That's, they had blisters on the feet. They had a, pain in the wrist from a fall. They had whatever. So this concept of people will be disappointed with different response times, probably not true. Now, for some of the calls, and I'm preaching to the choir here, you need to have quick response, but for, a large percentage of our responses, response time probably isn't a huge deal. And by the way, she went and did the coefficient correlation and found that there was no correlation between the ambulance arrival and the patient's perception of the timeliness, even up to 45 minutes. I mean, it's not a huge deal. By the way, this will be at EMS World next week. So those of you who are going to be there, we got approved for a poster presentation on this analysis. So this is an example of what's going to be out there. Okay, so we talked about this already. So, currently $6 million. What if we said, 7 minutes, 90%, but maybe we don't need all ALS. Let's go to a tiered deployment model. And if you do that, it does some savings, but you've still got a significant cost of readiness to get that 7-minute mark. And you're only going to save $500,000 if you go to a tiered response, but it's going to be much easier to find people, and we can, have lower overtime expense perhaps, because we're not having to hire all these paramedics on overtime. But again, be ready to have some of these conversations, because folks are going to ask you, what's the cost difference per hour between an ALS ambulance and a BLS ambulance? And you should know that. So you know what the expense difference is going to be. So again, we've got 6 million. What if we went to 9 minutes, 90% of the time, and tiered response? Now we're talking a $1.8 million savings. These are the conversations that we are having right now in Fort Worth and a number of other communities, because if you're going to start asking for tax dollars for the first time, people need to understand this, and what expense savings can we have to not have to spend $6 million in subsidy? Can we only do $4 million in subsidy and still have reasonable service delivery? So this helps you with some of that calculation, or at least those discussions. All right, after all that heavy calculations and boring droning on, some more signs. Am I getting older, or is the supermarket finally playing great music? Noticed this the other day at Kroger. It was kind of a scary thought. Never iron a 4-leaf clover. You don't want to press your luck. It's pretty good. This guy's brilliant. So once you have that information, it's a good idea to trend it over time. So this is an actual example of a monthly analysis that we do here at MedStar, and we want to track our expenses by unit hour, response, and transport. Now we do this for everything, not just ambulance, but for our mobile healthcare team and all that kind of stuff. But we want to trend this over time. because we want to know, are there things that are impacting our unit hour expense? Has the expense gone up, gone down? How's it being impacted? We also do the same thing, by the way, for revenue. So we do revenue per unit hour, revenue per response, revenue per transport, across the whole board. And we want to see how those lines are going to make sure that they don't cross. They're crossing now, which is why we're talking about, that particular thing. So you trend it. Now, this probably will look a lot like what you guys will do when you do this, but you'll notice that our expense per unit hour has gone up pretty steadily since 2019. Not surprising. Notice that our expense per response, though, dipped in 2020, 2021, which is our fiscal year crossover. That was the pandemic effect. Response volume tanked like it did in most communities. Because we are a flexibly deployed system, we flexed down. So we cut unit hours, didn't need them. We just reduced unit hour expense. So our expense per response went down because we were reducing our overall payroll expense. The unit hour expense stayed the same, but our overall payroll expense went down because we decreased a lot of units. And then obviously the expense per transport mirrored to a large extent the expense per response, given the transport ratio. Now, Public Consulting Group, PCG, has been a huge partner with NAEMT and a number of states. They do cost reporting. In order to grow their business, to do cost reports for agencies, they work very extensively with states to implement GEMT programs. And they've got legislation models, they've got language for regulations, they've got all sorts of things. And I got to tell you, Matt Sorrentino and James Dashos and the team, they do a phenomenal job, and they've implemented GEMT programs in many, many states across the country and do the vast majority of cost reporting for the agencies that are participating in that. Now, in Texas, they've been doing it for a long time, and they do our cost report, and they do a cost report for most of the agencies that are participating in the Ambulance Supplemental Payment Program. And they provide a summary every year to all of the participants. And we find this summary interesting. In 2018, which it actually, in terms of cost reporting, this is relatively current. I'm going to show you the 19 here in a minute. But notice the expense per transport for non-fire, back up, is about $935.29. Cost per transport for a non-fire department-based EMS agency. So this is county, this is third service municipal, this is MedStar, all of those data, all those agencies are in here. Fire-based, 2166. These are averages. Okay, this is us. This is why we did not like the cost-based reimbursement for the GEMT, because there were departments whose cost basis was $2,100, and they got a boatload more money than we did, even though their transport volume is identical to ours, but we received less dollars because our costs were low. So we explained to the Medicaid commissioner that agencies like us are being penalized for being efficient. And that's not how I want my tax dollars being spent. And why should we be rewarding inefficiency? Also notice that charges for the non-fire department-based systems were $1,390, essentially $1,400, ours $15, but the fire department-based systems generally undercharge because they get so much tax subsidy, and because local elected officials don't want people to to complain about the ambulance bill. They generally have low charges for their service. 2019, a little bit of a difference. So the non-fire EMS agency expenses went down, our expense went down, fire-based expenses went up pretty dramatically. Everybody's charges fluctuated a little bit, so the non-fire charges went down just a bit, fire went up just a bit, probably because we started having this conversation about the average commercial reimbursement, and they all said, holy crap, we got to start raising our rates to be a market rate to show the difference, because that's what the base is going to be. This is just a quick comparison between 19 and 18. So notice that the fire department's costs went up 21%, non-fire went down 5%, our expense went down 1.6%, charges went down. But again, PCG does a great job with this. We felt this was a treasure trove. Now this is just Texas data, all agencies. we, NEEMT, asked PCG if they would be willing to do the same analysis across the country. And we got it Monday, this past Monday. We're still analyzing it, but this is what PCG provided for us. We have it by state, so we can do some regional analysis. Tim's on the committee for NEEMT that we're working on this. But notice that the fire-based EMS providers across the country, the average cost per trip, taking outliers out, because there are some that are crazy and that probably just some are out of there, $2,600. The average cost per trip for EMS only services, $1,026. So the reason that we're doing this is twofold. One, to be able to go to Congress, to be able to go to Medicare, to go to Medicaid, to go to the commercial payers and say, you know, you're paying us $200, $300 for transport across the country. This is what it's costing, not just here in Texas, not just in Colorado, not just in California, which is where a lot of the outliers are, but this really gives us the cost base. But what it also lets us do is when Medicare starts releasing the results from their cost analysis, and they say, you know, the data is showing that an emergency ALS call is costing about $400. We can say, seriously? Did you leave off a decimal point doing the calculation? So this is a good way for us to sort of keep that process in check, because these are costs that in many cases states have submitted to CMS for the federal match, the federal share of the Medicaid dollars that comes back, which has then been reimbursed to the provider. So if Medicare comes out with some crazy number, we can say, you know, you've been funding the state of Colorado to the tune of $1,000 a call, a transport, for their public agencies, and now you're saying that those costs were wrong? Then what? I mean, what's the public policy ramifications for that? So we think this is going to be great information, and we're going to publish it widely. Here's an example of where cost calculation goes awry. Okay, so this was the amount of money that was just released in September to these agencies in Texas for their GEMT program. City of Houston, this is Houston Fire Department. Their reimbursement for the GEMT cost-based was $18.9 million. Their call volume is 30% higher than our call volume. Dallas Fire, their call volume is the same as our call volume. They got 11 million, 11.7. San Antonio, their response volume is actually slightly lower. They got 10 million. El Paso, half our call volume, 4 million. Austin Travis County, they do as many calls as Dallas. Their reimbursement, 2.8. MedStar, 1.7. So that was our whole point. How can Dallas Fire, with almost exactly the same response volume, get $11.7 million and we get 1.7? And when you look at their cost per call, $2,800 compared to our 403. That's the basic crux of the GEMT challenge that CMS, trust me, is going to start clawing money back, because they're going to say, Dallas, you included the cost of the engine, the cost of the people on the engine, and you can't include that. So of the, you know, let's say it's $11 million over the last 10 years, the $111 million that you've gotten, we want 10 million back. Overestimated your costs. And again, that's just showing what that's doing. All right, some more signs. To the thief who stole my glasses, I will find you. I have contacts. Man injured in bizarre peekaboo accident. He's in ICU. Tim, if you take out the accident word peekaboo ICU, do you get it? Okay. I know this is kind of hard sometimes. All right, I know that was a ton of information right out of the box, the first of your 2-day conference, but want to open it up and maybe Tim or Kim can moderate if anybody has any questions that they want to try and stump the speaker.
Are there questions from those online? Are there questions?
Sean, I'm really disappointed that you don't have like some factorial question.
I have two questions for you, Matt. One is just kind of a question of language as you're talking about this. I'm just looking for your opinion on this. So we throw around the word subsidy. And I wonder what your sense is of that being a loaded term, because that puts us in a situation as the EMS providers of saying, we need the handout from the government to make our thing work. But you never hear the word subsidy thrown around when we're talking about funding the police department or funding the fire department. Those are, I mean, I don't want to throw the word essential government services out there too much because who knows what that means and how to make it happen. But it seems like subsidy is almost a word that puts us at a disadvantage as soon as we say it. Do you share that opinion, or how has it interacted in the conversations you've had in Texas?
Very insightful, Sean. And I think the subsidy is a historic term when they contract for service and they got to provide a contract subsidy to get the level of service that they want. It's a horrible term. What we've been using here over the last 8 months that we've been talking about the need for a cost offset. So that's the term that we're using here. It's a cost offset. Here, it's costing us to do this. We're bringing in this revenue, so we need a cost offset to make the total revenue match the cost.
Thanks. May I ask a second question?
Yes, you
Kim, the other thing I was fascinated about your analysis with, Matt, was her kind of comparing the single role EMS and the single role fire. I think one of the things that we're seeing in the Colorado supplemental payment program, also run by PCG, is there are those who have the economy of scale and those who do not have the economy of scale. And it's kind of agnostic of what kind of public agency you are. But for example, I'm the 800 call a year small guy, and there's plenty of others like that in the room here. And I'm at the $5,400 a call mark because, you know, we don't have a lot of calls and we're dividing the whole cost of the thing into a pretty small number. How do you figure, I mean, I get where they're trying to say in Texas, stop shoveling all the money to the large fire agencies and punishing us for being efficient, but how do you think the economy of scale piece plays into that in terms of how's it going to work out with shoveling to the small guys versus shoveling money to the big guys? Excuse the shovel analogy.
Yeah, great question, Sean. And I think that comes down to, if you look at all the agencies that we were comparing here, they're all urban, they're all, you know, whatever. But the cost of readiness is really what you're talking about, that the cost of readiness to respond to your 800 calls is different than the cost of readiness responding to 180,000 calls. There's still some cost of readiness either way, but the call volume is so low, and that's why rural agencies and frontier agencies get a 22% bump in their Medicare payment, because Medicare recognizes that your cost of readiness is a different decimal point compared to other agencies. So yes, to the extent that GEMT programs should take that into account, the difference is that they do their cost analysis for the transport to only be the cost for the transport. I'm hoping that maybe because Colorado has some stipulation in the cost reporting that, you know, your overall cost divided by the number of transports. So in rural areas, you should have a cost per transport of $5,000 because that's what it costs you, because you're taking, you know, 14 hours of on duty time divided by one call. And that makes a ton of sense. So I think that does play into this. But when you see this in an urban area, it's just wrong.
Yes, Tim.
Just out of curiosity, could you bring up something in your last answer, are we going to discuss how to figure the actual transport cost versus the readiness costs? And my other question is, how do we address the inequity of the metropolitan service areas, the MSAs that determine who's an urban, who's a rural, and who's a super rural service? I mean, we were having a discussion last night between myself and Gilpin County Ambulance that because we're so close to a metropolitan area and a lot of our people commute out of our area for shopping, for work, for healthcare, they go down to Colorado Springs. Practically, call volume, transport volume, I'm a super rural service, but I am classified as an urban. So even when we talk about these national initiatives of keeping the bonus payments, why do I care? Does UPass and Gilpin County care what happens to those, whether we keep them or not? Because that 2% payment to us is, on our volume, is $4,000. Why do I care?
So Tim, you raised a really good point, as always. The working in reverse, the misclassification in the last determination of the Bureau of Labor Statistics, I think, who did the zip code analysis, was just flat wrong. And Medicare recognizes it, other people recognize it. Many of the zip codes that were appropriately classified as rural because of the wraparound for the metropolitan statistical area and even the census tracts were just wrong. And that puts a lot of, because you have to drive through Ute Pass to get to whatever the next big city is, now you're in that census tract and you're no longer a rural or frontier community because you've got people driving through it to go to a urban area, is just wrong. And there supposedly, when the extender bill gets passed sometime probably around December 28th, that fix is going to be in there, we hope, and then they'll go back and readjust. The cost of readiness or the payment for that, I think, is on the revenue side, but should be, again, if you've got to staff one unit 24/7 and your unit hour utilization is 0.0006, then your costs are per call are going to be much higher, and those should be counted. And they should be reimbursed for that cost of readiness because that's what the community expects. And honestly, if that's what they want, they need to pay for that. So if they're gonna fund $1 million a year to keep an ambulance on duty 24/7, they've got to commit to, because the revenue is going to be pretty low. They got to be willing to do that. So
isn't the UHU used to determine or to break out the cost of readiness versus the cost for transport, the direct cost? According to AAA, the UHU is used to do that.
it's one of the calculations. It can't be the sole. Because again, it depends on what the community's expectation is. And the discussion that we're having here in Fort Worth is, they're thinking about adjusting responses. And we're going through this reprioritization project, and we're saying, okay, if 30% of our call volume is going to be hot response and we got to be there in 10 minutes, that's great. We can't do it for no subsidy anymore. It's going to cost us, an additional 2.3 million. So this community's got to pony that up. And then they said, well, what if it were a 13-minute standard instead of 10-minute standard? And we said, well, what if we went to 10% of the calls are hot and the rest, as long as we get there within the hour, we're good, and we need no subsidy. It's really, what does the community want? What are they willing to pay for? And I said this sort of tongue in cheek, or I think Bryony's did it on the last EMS 1 podcast. What is the life worth? And we said, no, it's not what is the life worth. It's what does the elected official think the life is worth? What are they willing to pay for? And that's a tough discussion. But we have to have it. We have to be transparent. Open the book, show them, hey, 55 ambulances peak at 5 o'clock in the afternoon here in Fort Worth because we have to meet, an 11-minute response time 90% of the time. And you can't drive faster than 10 miles an hour anywhere in the community. If we had, 70% of our response volume changed to a 30-minute or a 45-minute response time standard, we could have 30 units on the street, which saves us, $6 million a year. Okay, pick what you want.
See that?
Yep.
You're gonna have to, you're not talking about much now.
Hey, one of the struggles that we've had here in Colorado with, with our supplemental program is assisting some of the privates to participate in that. And it appears from your list that that's maybe happening in Texas. So how are you qualifying for the GMT?
So in Texas and true GEMT, IGT, true has to be an agency owned by the government. So it's either fire department, public fire department, I should make that clear. It's MedStar, we're a governmental authority. It's, hospital district that collects taxes. It's, these public authorities. Private agencies are not eligible to participate in GEMT, which we all agree is wrong, because if Arlington, which is our city next door, pays a cost offset, Sean, to AMR, because they want a level of service in Arlington that the fee for service revenue will not support. So they need to provide funding for AMR to get that level of service. The city of Arlington should be able to get that money back, because Medicaid is underpaying, but it's not allowed. The provider assessment is generally all providers, regardless of provider type, right? Everybody participates, everybody kicks in, everybody helps with the money laundering, and they get the money back from the feds. But Texas does not have a provider assessment. It's been discussed. The legislature believes that is a tax, and we don't like taxes here in Texas, so it's never passed.
So Matt, this again, in Colorado, there was a push for a FRA to support the privates, and I think federal reimbursement.
Federal reimbursement.
Yeah, allowance. And I think that it kind of went away during the last legislative session because there was other priorities. But there has been a push by privates and supported by MSAC and others to do that, but has not been successful as yet.
Yeah, I mean, it's a great way to do it. It typically, if you do a provider assessment, I think that's what you're referring to. Typically, it requires money being put in order
Yes.
to get the money back, and everybody kind of hopes that the money they get back is more than the money they've put in. Generally, that works. If not, then you got to do a little bit of a workaround and do some additional spin cycle for the second round in the money laundering, that is. But it can be done, and it has been done. So now in California, and I know people love to hate California, but they combine. I love this. Their GEMT program, as we described here, cost-based, essentially has sunsetted. And I think did it very recently for some of the reasons I think that we're seeing come out of CMS. They are going to an IGT supplemental payment program that only, and it's a provider assessment, is only available to public agencies, not private agencies. So and by the way, the reimbursement that comes back to the city, the county, the public provider is like $800 a call. So their Medicaid reimbursement in California, starting in January, for public providers, not for private providers, will be close to $1,000 per Medicaid transport. It's crazy.
Matt, along those lines, it's Sean Caffrey again. And I know, I heard about them experimenting with this in California. I know Colorado Springs kicked it around in their last RFP piece. Are you seeing any of the deals in Texas where public provider is hiring the private provider as the subcontractor and just buying the unit hours in order for the public provider to get the reimbursement and then pass it through the chain? Are you starting to see any of those evolve?
We haven't started to see it in Texas. We are seeing it a lot in California. I do some consulting for a couple of agencies, and there's a couple of very large systems in San Diego County that do exactly that, where the county is the provider of record and they do the billing through a billing contractor, and they pay the provider, AMR. But the GMT dollars go to the county. And there are a number of agencies that do that so that they can leverage, but that means that the ambulance provider has to give up their ability to bill. The public agency then has to bill or contract with somebody to do the billing, which is okay. I've often said, so just contract with that agency to do their own billing and just have a different NPI that's assigned to the city, and everything stays the same. And we're working on that with a couple of other organizations that may work.
Tim, Matt, are you familiar with the recent CMS change regarding critical access hospitals that own their ambulance services? And Kim, help me make certain I get this question straight, so that, or Sean, I actually know, because it's a matter of and versus or. If the hospital-based critical access hospital restricts who can take patients into or out of that hospital, regardless of the mileage difference between these critical access hospitals, they can now qualify for cost-plus based reimbursements. I hear that is a recent change. Minnesota's jumping all over it. That change occurred out of Springfield, Colorado. And so there's a lot of services that are hospital-based critical access ambulance services that may qualify for cost-based plus reimbursements.
Yeah, and Tim, I'm not that familiar with it. I do know that forever, when critical access hospitals have been, they weren't cost-based fully, but they got Medicare enhanced reimbursements. They were allowed to include those costs. If they ran the ambulance service, they were able to include the losses they had from the ambulance service as part of their cost, and Medicare reimbursed that. So it wouldn't surprise me. They're trying to do everything they can, and now they have this new designation called a rural community hospital designation or something that allows critical access hospitals to not have to stay open 24 hours days a week, which is kind of weird, but CMS is trying a bunch of things just to try and keep hospitals in local communities. It wouldn't surprise me.
Other questions? Richard, you look like you have a question. Apparently not. Anybody online with a question? Okay, so for everybody's benefit, the slides presented by Matt today will be available. I'll send those out after the conference along with your bill. And those will, yeah, you have to pay it. Those will come out with that. Matt will be talking this afternoon about setting base rates. So this morning he was just talking about the cost of doing business. And this afternoon he's going to expand on that and talk about how to set base rates using the MedStar example. So we'll be looking forward to that. Is there anything else? Tim, you have a question?
Matt, could you give us a little bit more kind of a breakdown on how do you, when you talk about UHUs, your UHU is based on 1 hour, correct? So how do you modify that UHU to a response UHU and or a transport UHU if your, let's say, your average response time is an hour and 30 minutes and your average transport time is 2 hours and 45 minutes? How do you make that UHU calculation transition?
Great question, Tim. And that's why UHU really shouldn't be utilize to determine your cost, because in many cases, it's very irrelevant. So there's a factor, and it's basically based on your task time. So you are correct in that the UHU typically assumes that one call takes 1 hour. So if you have a 2.5 hour typical task time for a transport, or a 1 hour typical response time in your community, then you just have to multiply the number of unit hours that you have for the calculation by that factor of time. So if it takes you 90 minutes typically, then you literally have to, once you get your UHU, you multiply it by 90 or 1.5 actually, to show the true time on task utilization, instead of just the typical urban, it takes 1 hour to do a call UHU. And I'll include that in this, because that's included in the workbook. So that if you, and the flip side is true as well, by the way, Tim, is that if you are in an urban area, and I was just up in upstate New York working with the department up there, and believe it or not, their average task time for an ambulance transport was 39 minutes, because they've got a hospital right downtown. They've got a very little traffic issues. I looked at the data and said, okay, so we need to take your UHU and actually divide it, because your time on a task is less than an hour. So it works both ways.
Thank you. Matt, you had also mentioned a template workbook. You're going to include that?
Yes, sir. It'll be in your email by noon Central
Okay.
Time.
All right, very good. Thank you, sir. If there's nothing
Thank you all.
else, we will take a little extended break here and come back for Scott Moore at 10:30. Thank you, Matt.
Thank you all. See you in a little while.